Okay. Welcome back, everybody. Happy Friday. Hopefully the weather holds for the weekend. Okay. So today we're going to keep going, thinking about the female reproductive system, as well as walking through the events of fertilization and possible pregnancy. So a reminder of where we left off. Cool. Okay. So we had spoken about both our ovarian and uterine cycles. So we know we're dividing the menstrual cycle in half between a follicular phase and a luteal phase. Follicular phase, we've got follicles growing in the ovaries. Halfway through, we have ovulation. And then we pass into the luteal phase where we have this gland, the corpus luteum, growing in the ovary. And they match up imperfectly with our three uterine phases. And this is all being triggered by hormones. So we were looking at how we see in our early to mid follicular phase first, these rising levels of estrogen, right? These pretty much non-existent levels of progesterone as we see these follicles growing and developing and maturing, and how we get to the point where we have LH and FSH starting to spike, right? So we had seen that in the early and mid follicular phase, we've got the situation where FSH is being secreted by the anterior pituitary, but we've also got this negative feedback loop coming from inhibin in the granulosa cells that are surrounding our oocyte. We also know that we've got estrogen secreted by this growing follicle. As it's going up, it's suppressing LH and FSH, as well as kind of upstream suppressing the hypothalamus. Okay. Now, we have some general actions of estrogens that we'll mention before we get to how we see these hormonal changes changing in our phase right before ovulation, as well as into our luteal phase. So in addition to acting right now in this first early and mid part of the follicular phase as a suppressant on our LH and FSH, estrogens are doing all kinds of things, both within the reproductive tract and then later on in other phases in other parts of the body. So at this point in the follicular phase, the estrogen is promoting endometrial growth. It's eventually going to be acting on potentially duct tissue, fat deposition in the breasts, and it's going to work alongside a bunch of other hormones. Okay. In the late follicular phase, it acts fundamentally differently on your brain than it does in the earlier parts of the follicular phase. So we're going to notice here, as we get to these latest parts of the follicular phase, so we're somewhere around here, right? Estrogen has been suppressing the anterior pituitary and the hypothalamus, but now suddenly we've got this positive feedback. So once we see the estrogen levels reach kind of like a critical mass, you can think of it as, right? They stop suppressing, they stop doing negative feedback loop, they stop inhibiting. And now we've got this kind of snowball feedback loop, this positive feedback loop where we see LH and FSH shooting up as we see these levels of estrogen going up to these higher levels. So this is what's going to trigger our ovulation, particularly that LH surge. Okay. This is just a table from your book showing you the actions of progesterone. So this is a hormone that we're mainly going to see as we move into the luteal phase. So it's going to be helping with some of the uterine conditions in the secretory phase, so that latter part of the uterine cycle. It does other things in the rest of the body as well, both during normal everyday life in the luteal phase, but also in pregnancy. Okay, so let's look at the hormones in that luteal phase. So now we're talking about after ovulation. So we're talking about this whole second half of our menstrual cycle here, right? Okay. So we've had these spikes in FSH and LH. Maybe they're a little bit ongoing depending on exactly where we are, but if we're really in the luteal phase, they should be starting to go back down. And the reason for that is that they're acting on our new little gland, the corpus luteum. So that's the remainder of our ovarian follicle that's gotten left behind. So the oocyte and some cells around it left. The ovary headed into the fallopian tubes, but the rest of the tissue stayed around, kept producing hormones. And in addition to producing inhibin and estrogen, which we saw some of in the follicular phase, it's now also producing progesterone. So we can tell from a graph pretty easily that we're in the luteal phase if we see these levels of progesterone at kind of any significant level, right? They're basically zero in the follicular phase. Okay, so this is part of why we don't see that LH surge or the spike in FSH continuing or reoccurring, because progesterone is a really strong inhibitor of the secretion of these hormones from both the anterior pituitary and the hypothalamus. So as soon as the corpus luteum is making this progesterone, it drops those two hormones way down. So that's why we see this come down first fast, but then it stays down and keeps going down a little bit, right? So that's the progesterone. It's particularly affecting the LH because inhibin kind of does its own thing with FSH, which is why the FSH was never quite as high as LH to begin with. Estrogen is back in the luteal phase here. So we can see that the estrogen is going back up, right? So this might be noticeable from a personal level if you're responding to the estrogen in your own body, right? And this is not going to trigger a new LH surge, which it would otherwise because of that progesterone. All right. So these hormones are really important in the menstrual cycle for regulating the events of menstruation, but they're also important from a kind of larger time scale if we're thinking about lifespan. So particularly during puberty, we think about estrogen. Really, we think about estrogen more than progesterone, but don't want you to forget about progesterone because it's that hormone of the luteal phase and it's doing its own important job. But estrogen, this female sex hormone, is primarily responsible for producing secondary sex characteristics during puberty. So that's going to involve widening of hips. It's going to include changes to fat distribution. So you're going to see fat pads in the breasts, hips, and buttocks growing in response to the beginning of this estrogen cycling and production during puberty. Produces some skin oil, body hair changes, and helps a bit with bone growth. The estrogen levels should remain relatively high throughout the reproductive years, right? So we can see, all right, relatively high if you average it out in the follicular phase, relatively high if you average it out over the luteal phase. So they are working, those estrogen levels, to maintain those secondary sex characteristics as well. So when we head into menopause later in life, right, basically when we run out of oocytes and fertility starts to shut down, we see these estrogen levels decreasing because part of where those estrogens were coming from were the follicles in the ovaries, right? So estrogen levels are going to go down. And this does have an effect on some of the secondary sex characteristics. So you're going to see some changes to things like the fat deposition. So like hips and breasts and those characteristics will shift a little bit as you see estrogen levels lower. Might also be related to hot flashes. So some kind of thermoregulatory effects get kind of funky in menopause. And once we have these new levels of hormones in menopause, right? Lower estrogen in particular, we're going to see changes to the risks for certain diseases in women. So earlier in life, women are less likely to get heart disease. After menopause, when we see these hormones going down, estrogen levels decrease, that risk ticks up. Estrogen has also been helping with bone growth in puberty. When estrogen goes down in menopause, we now have a risk for osteoporosis. So basically bones getting brittle and eating away at themselves. So we see some physical changes that are important in response to these hormonal changes. So doctors may prescribe, supplements to estrogen, things like that, in order to kind of mitigate some of these side effects. Okay. So we're now going to talk about fertilization and implantation and a little bit about what's going on with our early embryonic development. So I just want to remind you about some of the anatomical parts related to this because we're about to use these words, right? So in our female reproductive system, we've got our ovaries, and then we have our fallopian tubes. The fallopian tubes have fimbriae or fingers on the ends of them. We then go into an infundibulum as we're pinching off. And we have an ampulla. And then the rest of the fallopian tube goes into something called the isthmus. That's not on this list, but as we're curving in towards our uterus. Right. And then we have a fundus to the uterus. So we can think of that as kind of the top, a body to the uterus. All right. And then at the end, we've got a cervix. Right. And that is projecting into the vaginal canal, which heads out of the body, right? So this is the kind of situation we're working with. Right. So when we think about fertilization, the reason I'm pointing out these terms, I can do that. Oh, should have done these in a different order. But the reason we're tracking these is because as we think about where fertilization happens and where implantation happens, right, we're going to want to be able to kind of picture these locations in our mind because it's not necessarily where you would expect, I guess is kind of my point here. Okay. All right. Which is that fertilization is usually happening not in the vagina, it's happening up in the uterine tube, it's happening up in the fallopian tubes, and it's usually actually happening kind of far out, kind of most of the way out towards the ovaries. Okay. So if we're thinking about fertilization, right, we're thinking about sperm and egg cell coming together, right? We got a kind of timing issue here, timing opportunity. I don't know what we want to call it. Okay. But we have an oocyte and a sperm that have different lifespans, basically. So the oocyte is going to be released at ovulation around day 14 of the menstrual cycle, and it can only survive for 12 to 24 hours. So it's only viable to be fertilized for a day, right? So if it doesn't encounter sperm within that 24 hours or so, no fertilization will occur. Okay. The sperm, however, have a longer lifespan. So they have to travel kind of far. They've got 5 days, basically, to survive to reach fertilization. Okay. So when we're tracking whether fertilization is likely to occur or not, we've got to pay attention to, yes, is ovulation happening now? But we might also be thinking about, okay, are there sperm already in the reproductive tract? They've got a little bit of time before they die off, okay? So sperm introduced into the reproductive tract usually a little bit before ovulation are probably the ones that are going to actually successfully fertilize an oocyte. At the point that they are deposited into the reproductive tract, though, they're not actually fully capable of fertilization yet. they need to undergo this process called capacitation. Capacitation helps them swim better and also changes some of the properties of the enzymes and membranes that actually enable them to fuse with the oocyte. They don't undergo those changes until they're actually in the female reproductive tract. Yeah. So that's happening with the sperm. And on the female side, we have this oocyte that has to explode out of the ovary, basically. So we have the antrum bursting and this fluid movement causing the oocyte to physically move towards those finger processes, those fimbriae at the end of the uterine tubes. We got a little bit of a peristaltic contraction going on in the tubes themselves that move the oocyte towards the uterus. And then after those peristaltic contractions stop, we also have some cilia in the walls of the fallopian tubes that continue to kind of push the oocyte towards the uterus for a couple more days. Overall, it takes them 4 days to get to the uterus. So if there were sperm just waiting around in the uterus to fertilize an egg, pretty much fertilization will like never happen, because by the time that the ovum reaches the uterus, that's more than 12 to 24 hours, right? So the sperm that are able to actually fertilize one of these oocytes have to get up to where that oocyte is 12 to 24 hours after ovulation. We'll trace a picture in a second. Yeah. So if we're thinking about those sperm, about millions of them are deposited into the vagina during copulation, right? And they're swimming. So they have to go through the vagina, they have to go through the cervix, they have to go into the uterus. And then they have to make their way from the uterus to the opening of the fallopian tubes, right? The uterine tubes. And then they have to swim their way up the uterine tube, right? So they've got 5 days to make it up and out towards that maybe like ampulla infundibulum area out by the ovary where the fimbriae are waiting to catch an oocyte during ovulation. Only a few hundred sperm actually make it to the uterine tubes. For a bunch of reasons. Basically, this is kind of hard. It's far to go. They have to swim right. They have to get to the opening. There are a bunch of different ways that this can be ineffective. So this capacitation that's happening in the female reproductive tract might also not work on absolutely all the sperm. And it has to, because their tails aren't going to work right. They're not going to be able to actually swim at the right frequency up the uterine tubes successfully if it doesn't happen. And if the tails are moving right and they manage to make it there, the other thing that capacitation is letting them do is to kind of break into the oocyte, right? Because we have the oocyte coming out at ovulation, but we do still have a couple other layers of cells around. We've got the zona pellucida and we've got the corona radiata around them as well that have kind of come with the oocyte during ovulation. So this capacitation process lets the sperm get through those layers too. Yeah. So let's look at a picture because that's better. All right. So we're thinking about sperm. They've got 5 days to take their journey, right? So they're coming in to the uterus. They got to go out into the uterine tube, right? And they got to make it pretty far because the reverse trip to the uterus would take our egg, our oocyte, 4 days, right? But that oocyte only has maximum like 24 hours. So the oocyte is only going to get to about here before it stops being fertile, basically. So the sperm have their 5 days to try and make it out there, right? I'm not exactly sure how fast they can do it. I have not checked to see if anybody's timed how long a single sperm can get to the end of the fallopian tube if it's got effective tail movement. Something to Google later. Yeah, but they got to make it most of the way there. And they gotta make it to at least here because our oocyte is not likely to be fertilized past this point. So we can see these little sperm cells here coming in to try to fertilize this oocyte with its layers still around it. So the oocyte being that purple in the middle, you can see there's a little more stuff still around it. Okay. So if we've got these sperm, the first one that gets there, it's undergone capacitation as it was passing through the reproductive tract. It's got these enzymes in the acrosome in the head of the sperm, in addition to having like the chromosomes in the nucleus there. They're going to let it break in and deposit its genetic material. Once it does that, there are some mechanisms that prevent the other sperm from also fertilizing that same oocyte. If other sperm get in there and also do manage to fertilize that same oocyte, then that's not going to work. Like that, it's considered polyspermy. That's going to end up just a cell that's going to be eliminated from the body, right? So we need just one to get in there. Okay. So we fertilized an ovum out here somewhere near the end of the fallopian tube. Okay. And we're now going to call it a zygote. Okay. So thing to remember here is like right at this point, as the sperm is fertilizing, that this oocyte finally undergoes the end of meiosis, right? So we had this really long process of meiosis when we're looking at ovaries and we're looking at follicles. It started before birth. We were in meiotic arrest somewhere in the beginning phases of meiosis 1. We finished up meiosis 1 at ovulation, kept going a little bit into meiosis 2, but it doesn't end until this ovum gets successfully fertilized. Okay, so as we fertilize, we finish up meiosis. Now we have this fertilized ovum here. And you can see that we have this outer layer still kind of attached to zona pellucida. Okay. So this fertilized ovum is going to take that 4-day trip to the uterus now. And as it's going to be dividing. So there are all sorts of special names for this growing embryo as it goes through these like levels of division. We're probably really just going to refer to it as an embryo after it's successfully implanted and started to do some of the successful phases of starting to develop different layers and parts, because not all fertilized ova are going to successfully implant, and the ones that don't will just get washed out during the menstrual phase anyway. So we are dividing, all right? So as we're going through, we divide into a 4-cell stage in early cleavage. We keep dividing into a mass called a morula as we're continuing to pass in towards the uterus, not all the way there yet. We can see these are a bunch of little small cells. I think this is named after like looking like a blackberry. Then we have a blastocyst forming. At this point, we can see we've got a bunch of cells kind of on one side of the mass. And then we've got this kind of cavity called a blastocele over here. So this is what's actually coming into the uterus if we have fertilization successfully occur. All right, so we have this blastocyst about 4 to 5 days post-fertilization, making it to the uterus. And now it's got to implant. It's going to try to do this usually somewhere near the top of the uterus. What it has to do is it has to actually attach itself to the lining of the uterus. So we can see here this implantation on our diagram happening 6-ish days after fertilization. All right, so we can see during this implantation part, we've got that cell mass towards the side where we have all the blood vessels of the uterus and the epithelial lining of the uterus. We've got this larger cavity kind of on the outside. And to successfully implant, it's going to need to start to grow its way towards those blood vessels, grow its way kind of into the tissue of the uterus. After that, we start forming an amniotic cavity, and eventually we'll start forming other structures that are ultimately going to lead to you and me. Okay. But it takes a while, and there are a lot of tricky steps. One kind of cool thing that we can think about as we're looking at this particular image, fun fact, is that early in these phases of division, like any one of these little cells has the power to make every cell in a human body. They can, yeah, they're like pluripotent stem cells. So if this mass kind of divides in half by accident and actually separates partway down here, that's how you end up with identical twins. So lots of complicated stuff going on and lots of possibilities. Okay, so that's what happens if we have fertilization occur and we want a pregnancy to occur and everything's going right. Sometimes we don't. I think it's worth a minute to think about how birth control plays a role in changing fertility, because a lot of this works with either the anatomy of our reproductive tracts or with these hormones that we've been tracking. Right. So fundamentally, if we don't want pregnancy to occur, we got a lot of options. We can stop sperm from reaching the oocyte in the first place. It's got a long way to go anyway, right? So that's not necessarily the hardest task, right? We can also prevent ovaries from releasing an egg cell. That's pretty cool, right? So we've seen how we have all these hormonal triggers that we need for ovulation to occur. So we can actually change hormonal levels to prevent ovulation. We can damage sperm so they can't physically move very well or can't actually fertilize an oocyte that's there. We can change the opening to the uterus. So we can change the cervix and the thickness of cervical mucus to block sperm. And we could also potentially change the uterine lining so that implantation of an egg isn't successful. Okay. So we kind of put different forms of birth control into kind of different buckets. So the most effective one is going to be sterilization. In sterilization, you just like cut the tubes, right? So this is very much an anatomy method. So in female anatomy, tubal ligation means we are snipping these fallopian tubes, these uterine tubes, right? So we could still ovulate, the oocyte could still go somewhere, but it's not going to make it to the uterus, and any sperm that come in are not going to make it out towards the ovary either. Easier to do sterilization in males, also reversible, because all we have to do is make a quick snip or block in the vas deferens. So that means sperm are still produced, all the hormones are working normally, but as the sperm are headed back up and into the body, they reach this block and can't move further. Okay. We have a bunch of barrier methods, so anything that puts a barrier between the sperm and egg. So we have a variety of condom types. We have diaphragms, cervical caps, sponges, in general, just trying to stop sperm from actually reaching an egg. And then we have our hormonal methods. There are a number of different hormones and kind of synthesized hormones that our different hormonal methods can contain, but ultimately these are usually going to be working more on that ovulation side. A lot of them, what they do is prevent ovulation, so there's just no oocyte there to be fertilized in the first place. Okay. So if we're thinking about birth control pill, relatively common method, this is one of those things that's going to work by preventing ovulation, usually, maybe also preventing fertilization. We'll get to what I mean by that. Okay. So because it's working on hormones, right? It's working on hormones in order to prevent ovulation, but that means there are also other changes that you see in the body in response to taking these hormones, right? Some of them are great. It's like a 50% decreased risk of getting ovarian cancer if you take hormonal birth control, 30% decreased risk of getting endometrial cancer, right? Because we know these hormones are really acting on the ovaries. They're really acting on the uterus and that endometrial lining, right? So turns out that if you take these hormones, you're less likely to have mutant cells that grow and turn into a cancerous mass. Also help with severe cramps, PMS, and anemia. Anemia may seem a little random, but remember during menstruation, you lose blood, which means you lose red blood cells, means you lose hemoglobin, right? So because you don't see all these same changes during menstruation, if you're on a birth control pill, can help with that. Also prevents ovarian cysts sometimes, and it can even treat things like acne and excessive hair growth because those are also linked up with these reproductive hormones. So being exactly precise about what effects any given person would see, you need to know specifically what pill, specifically what formulation, specifically what they're dealing with. But it's not just about birth control. But if we do think about that part, right, usually the main thing that we're going to be looking at, or a thing that we can pick out at this point and understand from our discussion of the reproductive system, is the fact that these birth control pills are going to contain estrogen often, right? So there's usually estrogen in the pill. And what that does is it's going to act like it did in that early to mid follicular phase diagram. It's going to be acting in this negative feedback way to suppress the LH surge, right? So when we see no LH surge, that means the oocyte just like doesn't keep maturing, the follicles don't keep maturing, and ovulation just doesn't occur. Things just get reabsorbed, basically. Okay. So this is what we're talking about. We're gonna bring down this LH, right? So it'd just be, well, you might see some fluctuation, but it's gonna stay relatively like flat, right? And without this trigger for ovulation, no oocyte, nothing to fertilize. It does also contain progestin, so it's a little bit more complicated and might include more things, might include less things, depending on what your patient is taking. But one of the things that progestin can do is it kind of acts in a way that mimics part of the secretory phase of the uterine cycle. So it creates this thick cervical mucus. Right? Sorry, guys. Okay, back. Yeah. Okay. Well, not the best color to circle it in, but you can see down here. Right. So one of the things that we were doing in the secretory phase of the uterine cycle was thickening the cervical mucus to prevent like pathogens and stuff from coming into the uterus in case we have a pregnancy that has implanted and is growing. Progestin basically mimics that same effect, creates this thick cervical mucus, and this blocks sperm that are coming into the uterus as well. Oral contraceptives can be super useful, both for preventing pregnancy, also for preventing ovarian cancer, uterine cancer, et cetera, but not everybody should take them. Whenever you're counseling a patient, you want to think about what their specific risks are. People who are at an increased stroke risk in general or have risk of blood clots shouldn't take them because they can basically cause strokes at surprisingly young ages. And another thing to be aware of if you are working with patients, counseling them on what contraceptives they might or might not want to take is to make sure you tell them that oral contraceptives might not always work. There are certain things that basically inactivate them. One being just like, if it's an oral contraceptive and you're vomiting or you have diarrhea, then you're not going to be absorbing those hormones and they're not going to be that effective. There are also other medications that interact with them. Antibiotics inactivate oral contraceptives, so do some antifungals, anti-seizure meds, and a specific herbal supplement, St. John's wort, doesn't play nice with like a lot of medication, including oral birth control. You also have to pay attention to body size, body weight. Some research shows that birth control pill doesn't work so well in significantly overweight women. Another sort of form of oral contraception, but not like a daily one, when we think about emergency contraception, but actually works in a similar way. So emergency contraceptive pills are for additional protection after intercourse if you've been using like a barrier method and it didn't work, or just paranoid, I don't know, whatever. Some people use emergency contraception when they need it. It's not going to work all the time. And the reason it's not going to work all the time is because of these hormonal cycles that we've just been talking about. So what the emergency contraceptive pills do is they prevent ovulation. So they're basically going to work if you're in the follicular phase, right? So if there is no oocyte yet in the fallopian tube, right? If you're anywhere before ovulation, they're going to be able to prevent ovulation, in which case no fertilization can occur. If you're in the luteal phase, if it's 24 hours after ovulation, the egg already is infertile, so no fertilization would have occurred. But if you're in this unlucky point where that ovulation has already occurred and the oocyte is still in that 12 to 24 hours where it's able to be fertilized, emergency contraception is going to do basically nothing. Right. So the way this works, right, is the same way that we prevent ovulation with the sort of daily hormonal birth control. Same thing, but acting really quickly. Currently, the American College of Obstetricians and Gynecologists recommends using long-acting reversible contraceptives in most patients. So what they mean there are IUDs and contraceptive implants. The reason they do that is because they're more effective. So just a FYI about how effective different birth control methods are. This chart is going through how many pregnancies will happen in 100 women using that specific method for a year. So something that people can use for birth control if they have a really regular menstrual cycle and are really aware of their own bodies and are well trained, are fertility awareness-based methods. It's a bad idea to read your textbook and tell people, oh, so long as you don't have sex like day 14 after your period, you're good. That is not accurate. That is not how these methods work. Unfortunately, some people do tend to advise that way or think that way, which is what leads to their high kind of failure rates. But what you'd be doing here is tracking changes in like cervical mucus, which we know changes across the uterine cycle, right? So you'd be able to tell, are we in the secretor phase? Are we in the proliferative phase, right? Which would tell you something about where you are relative to ovulation. There are also slight temperature changes across the course of the menstrual cycle. So you can kind of figure out when ovulation is occurring. And that's the goal here, is to just predict when ovulation is and not have any sperm in the reproductive tract when ovulation is occurring to prevent pregnancy. Barrier methods are a little bit more effective, about 18% failure rate here. This is because in particular, patients aren't that great at using them perfectly every time. None of us are perfect. Our hormonal methods tend to do pretty well. So about 6 to 12% of women will get pregnant in a year if you're using injections, pills, patches, vaginal rings, or diaphragms. Again, a lot of this has to do with perfect use versus typical use, because we are trying to very precisely regulate a hormonal cycle. That can be kind of hard. Things can vary, and you have to be perhaps more precise than people are able to be in their everyday life. which is why these long-acting reversible contraceptive methods tend to be recommended. Patients don't have to really think about them or do anything in order for them to work effectively. So there's none of this kind of human error step here. So the implant, the IUD, and if you did a tubal ligation, permanent sterilization, going to result in less than one pregnancy, or less than 1% failure rate in 100 women a year or all women. IUDs in particular have become pretty popular. There are two kinds, just so you know. There's a hormonal one and there's a non-hormonal one. They work a little bit differently. The hormonal one obviously works by attempting to mimic natural hormones to prevent fertilization, in this case, as well as potentially ovulation, but usually it's the fertilization piece in the case of most hormonal IUDs. Non-hormonal IUDs change the kind of chemical environment in the female reproductive tract in a way that also prevents pregnancy. So these long-acting reversible contraceptives differ a little bit in how they work, despite the fact that they're all quite effective. The implant goes in your arm, works the way a lot of the other hormonal methods do, preventing ovulation. Copper IUD is non-hormonal. It's just producing this inflammatory response that sperm can't handle in the female reproductive tract. And we know that sperm, in addition to needing to get into the female reproductive tract, need to undergo capacitation in order to fertilize stuff, right? So that's kind of related to how this is working. And then the hormonal IUDs work mostly by thickening the cervical mucus to physically block the sperm. So like that image of progestin creating that thick cervical mucus cap, a lot of the function of a hormonal IUD is that. It may also suppress ovulation. There are also some papers out there discussing whether or not they also prevent implantation. You can find some studies either way on those, but when we look at how they work in practice and what we see in patients, we do notice that an IUD doesn't disrupt any pregnancy that's already implanted. So sometimes people put in IUDs like as an emergency contraceptive, but if implantation has already happened, fertilization has already happened, that's not going to disrupt a pregnancy. And there are still some very extremely rare cases where we have successful pregnancies happening with IUDs still in place. You'll see pictures of like little newborn babies holding an IUD. I think most of them are fake, but has happened once in a while. So jury's out on that last little piece. Okay, so that's just a little bit of a taste of the kind of clinical and personal impact that these hormonal cycles that we're talking about in this unit have on people's lives. Okay, so we were looking at our estrogen, right? We know that estrogen is spiking in the follicular phase as well as in the luteal phase. We looked at progesterone just in the luteal phase. We know that we've got these spikes of LH and FSH right before ovulation, LH in particular being the important one. This is what we're suppressing with a lot of our hormonal birth control methods in order to prevent ovulation. We know that these things match up with our ovarian and uterine cycles. So follicular phase and luteal phase, right in half across ovulation. We're looking at the uterus starting at day 1 is when we see our menstrual phase shedding the uterine lining before moving into the proliferative phase as we start to kind of grow it back. And then after ovulation, the secretory phase where we're preparing to potentially feed a growing embryo if we've had fertilization and successful implantation somewhere in the middle here. Okay. So that leads us to our very final topic, which are our hormonal changes during pregnancy. Okay. So now, instead of looking at these hormones over the course of 28 days, we're looking at it over the course of approximately 9-ish months. Side note, when we are counting timing relative to pregnancy, we're not actually counting from fertilization, since it's a little bit difficult to figure out exactly when that would have happened if someone's pregnant. So this is always being counted since the start of the last menstrual period. So anyone in like the last day of the anybody in the last day or so of the follicular phase is always kind of almost potentially 2 weeks pregnant already, because doctors actually start counting day 0 when the last menstrual period began, rather than when ovulation and fertilization occurred. Okay. So over this length of time, we're going to see estrogen and progesterone both have big roles. So estrogen is going to need to grow the duct tissue in the breasts. Ducts in the breasts are going to be really important because that's where we're going to have milk coming out during lactation. Estrogen is also increasing prolactin secretion. So prolactin is going to be a hormone also related to this lactation. And estrogen is also going to be growing the smooth muscle in the uterus and increasing its ability to contract. That's going to be important during labor, because that uterus is going to have to push out a baby. Okay? We also want to keep in mind that oxytocin is another hormone coming from the posterior pituitary. This is also going to be involved here in these latter parts of pregnancy as we get towards parturition or birth. Now, from the progesterone side, progesterone is going to be growing the glands in the breast. So we need both the ducts for milk to grow, and we need the glands to produce milk growing. So progesterone is doing the glandular tissue. Progesterone is also maintaining the secretory phase uterine conditions. So we don't want to go back to the menstrual phase if we have a pregnancy implant. So progesterone is going to keep the uterus feeding this growing embryo and feeding this growing fetus. And it's going to be suppressing the smooth muscle in the uterus. So estrogen is making that uterus smooth muscle grow. Progesterone is making sure that it doesn't start contracting before it's time to go into labor and time to give birth. Okay, so we'll pop back here on Monday, and we'll do a bunch of review over the next 2 days as well before our exam, and then heading into finals.